Ya podemos iniciar.
So, good morning, good evening, good night for everyone. I'm Sonia Carreño Moreno, and with Dr. Lorena Sanchez Rubio, we are leading this Colombian team for this 30th Virtual Global Health Hub. It's a great pleasure to have you here with us to share something from Colombia. We are going to have many surprises today. And thank you. We want to express our thankfulness to you for attending this meeting. I want to introduce you our team. So please raise your hand and say hello. Daniel Guerrero, PhD student from the United States, Purdue University. Daniela Garzón from Colombia, undergraduate student. Lorena Sánchez Rubio, Dr. Lorena Sánchez Rubio from Universidad del Tolima in Colombia. Nurse, Lina Ubake. She is going to be our presenter for today. She is an aspirant to a PhD in United States right now. Cristian Cifuente is a master student and our IT support. Say hello, Christian, please. Dr. Onés del Carmen de Arco Canoles is a professor from Universidad Nacional de Colombia. Student Laura Carranza is an undergraduate student. She is going to be connected from Boyacá, that is a city in Colombia. And Juan Jose Lopez is an undergraduate student too. He is going to be our moderator today. Thank you all for your support. We can begin with our agenda. So for our agenda today, we have a surprise. I want to introduce our country. Do you know that Colombia has a very special drink, a very famous drink? What drink do you think that is? Please put in the chat.
Sorry, Sonia, could you repeat the last part one more time?
Do you know what is the most famous drink in Colombia? It's a drink that we take in the mornings for having breakfast.
Got it.
Yes, Colombian coffee. So for opening this hub, we have a video it was made by Colombian students. We have a group in our university that has an association of coffee makers. So we are going to offer you a master class about how to make a very great coffee. Please, Christian, can you share the video, please? Enjoy it.
The Coffee Club is a space that seeks to encourage the consumptions of specialty coffee and mainly the consumptions of coffee produced by families in the university community, while generating a space for a social and solidarity economy that provides them with the fair payment to the producing families, giving them a premium price for quality.
Hi, my name is Santiago Parra. I'm a student of mechanical engineering at the National University in Colombia. Also too, I'm barista. We made the group Coffee Club. This group tried to make that the community of the university drink better coffee. For the day of today, we're gonna make a specialty coffee. This is a coffee from the department of Huila. This coffee won some prizes And this is the variety red bourbon with 400 hours of firm, and the process natural. For this drink, we're gonna use this specialty method of extraction. It's called Chemex. This method was invented by the chemistry of Germany, Peter J. Slumbo. It's thinking on some elements you can find in chemistry lab. For this method was made of glass, one kind of glass, are borosilicate glass, who are tinted for high temperatures, and we have some handle of wood and this body of belt that we can take it in high temperatures. For this drink, we're gonna use a paper filter like that. This is some kind of paper filter, more like that. This filter led us to prepare a really clean drink. For that reason, Chemex was one of the most popular methods to prepare specialty coffee, because Chemex usually the drinks made by Chemex are usually acids, are flour, that are there are some attributes we really want in our drink. Well, the first step is to clean the filter. We add some hot water to clean this smell of paper that we don't want in our drink. Yeah, this water we're gonna drop it. We're gonna retire of our drink. Yeah. Once we retire this water, we're gonna add our coffee, previously grinded. We use medium grind coffee, and we always try to grind like 30 or like not more like 5 minutes before making the coffee. We're gonna add our coffee. This time we're gonna use 50 grams to prepare 800 milliliters of coffee. We use our ratio was 1 to 16. That's like per 1 grams of coffee we're gonna use 16 grams of water, and where the density of water are the same that one, so milliliters are equal to grams in water. Well, we're gonna start the time. We put our Gramera in 0, and we're gonna begin. We're gonna start to add 80 grams of waters. It's like the 10% of all drink, and we're gonna wait like 30 or like 40 seconds, and we wait for the we wait for the coffee have a really good oxygen, and past 30 seconds we're gonna continue our preparation.
Chemex is one of the most famous specialty coffee preparation methods for its elegance and great ease in obtaining more complex cups.
We want to invite all the people, not only in the National University. No. The idea is that all people drink day per day better coffee. Why? Because the specialty coffee have really good signs for health, because we usually use some varieties with less caffeine. And the second is the roast point. Usually, the darkest one coffees are bad for the health because those roads are coming in pyrolytics coffee that are not good for the health. And this coffee made us on these methods that you prepare the coffee in 5 or 7 minutes have less caffeine, because caffeine was the caffeine it's really a drug, yeah, but the caffeine is hydrolyzed by the water. So if in more time of our grind coffee pass with water, we're gonna extract more caffeine that we don't want in our final drink. Yeah, that's the idea, to use these kind of methods. Well, we're gonna finish 800 grams of water. Finish this presentation, we want to invite all of you to come into Colombia, to come into the National University, and share with us a really good coffee, Colombian coffee. We're gonna hope to open the first specialty lab coffee in the National University. This hope to open the doors this 15th of January. And we want to offer to you a specialty coffee principle for the families or National University, families of students, families or professors. And we always gonna always gonna work with coffees with minimum 80 points. That's all. That's our coffee. That's our method for the day of today. And we hope tomorrow you can drink the same coffee, this coffee with us.
Okay, we all Colombians begin the day with a very great coffee. I have my coffee here. And I want to introduce you, Santiago Parra. Please, Santiago, turn on your camera. Hello, Santiago. Welcome for this virtual global health hub. Santiago is our barista. Barista is a person that is a specialist in make coffee and taste coffee. So we have here Santiago to answer many questions if you have. We are coming to Colombia, said Dr. Danet. Welcome, Dr. Danet, to Colombia. And at first, I want to tell you that Santiago is a mechanical engineering student and is also our barista in Universidad Nacional de Colombia. Santiago, why a mechanical engineer is a specialist in coffee? Please tell us.
Okay. Hi, good morning to everyone. So, yeah, that question makes me many people because if you thought that mechanical engineers are a completely different world with coffee, but when the pass of the time, you must gonna learn that they have many common things. For example, in Colombia, we have not a really good mechanical machines for coffee farms. That's one of the biggest problems here. And I would say, I would say some friends, for some coworkers at the university, I say I find more ways for the mechanical engineer in coffee that before of that. So I'm actually all my signatures in the university. I try to always to in focus, on coffee. For example, like 2 semesters before, I have a signature about machine design, and I always and I for this signature I made a coffee machine. It's one of the coffee that it uses for some part of the coffee process. It's called let me second this. I don't know the name in English. So um, well, let's say pulper. It's one of the first process of the coffee once we recollect. Yeah.
Thank you, Santiago. We have only a few minutes here for your presentation, so please give us some advices to enjoy a very great coffee.
Okay. The first thing is that the common persons don't like acid things or or wait a minute. Or bitter things. Yeah, usually the people don't like those flavors, acid and bitter, because we evolved letting those flavors before. Because, for example, in some fruits where are so acid are are bad fruits, and in the beef, for example, the bitter beef are bad beef, are discomposed beef. So we evolve who like separate these flavors because we always thought that are bad flavors. So when begin in this world, and not only in this world, when we begin in beer, coffee, wine, cheese, we must have to re-educate our taste. And for the reason we talk about like taste acquire, yeah, like we adaptate our feelings to identify the flavors in bitter, in acid. Because for example, in coffee, one of the most important one of the most important flavor are the acid part. So the idea is to drink a really good coffee and to appreciate a really good coffee. The idea is begin to make the exercise the first to drink coffee without sugar. That's the first thing. And once we practice and once we elaborate more our feelings, we're gonna start to feel more things in coffee. Yeah. One of the most important exercise for the coffee taster are to improve their sensorial memory. And one of the exercise we do, sorry, one of the exercise we do is to put some fruits, some spices, some uh, usually some flowers in glasses, and the first we smell it without anything. The second time is all of these fruits and flowers and spices. We add the half glass of hot water, and we smell the change, and we taste this water, this infusion. And the third time is to all of these glasses we add the second half of the glass with neutral coffee, and we're gonna start to feel to identify all these flavors in coffee. For example, I will say when I was tasting coffee, for example, I say, oh, this coffee taste or smell like, I don't know, like apple, for example. And some people who didn't make this exercise say, I ate apple, I smell apple, may I taste apple juice, and they don't feel the same as apple. Yeah. But why? The idea is to identify how apple express all these flavors in coffee. That's the first idea of this exercise. Yeah.
Thank you so much, Santiago. So this was a bit of Colombia in our hub. This drink is a very special drink for us. We always begin our mornings with a cup of coffee. And also we support this project for our university because it's a social projection project to have a network of coffee makers and coffee producers is a real amazing work in our university. So remember, don't put sugar in your coffee. Don't put sugar. Enjoy the taste of the coffee in a very clear way. You watch that Santiago put a filter to make the coffee. So always we need a filter because dark coffee isn't good. We need to take a clear coffee. Only the flowers, sorry, I don't know. I forgot the word, but we need to have a filter. And please don't put coffee into a cup and put water only. No. Make your coffee with a special machine or method like Chemex is the better method that exists. Thank you so much, Santiago. Enjoy this holiday. Thank you. Bye.
Okay, bye.
So we are going to begin with our academic agenda. And please, Juan Jose, you can start with the moderation. Thank you.
Okay, thank you so much, Professor. Okay, good morning for everyone, and welcome. First, we will have our opening conference, a prescription of medication in nursing, context, trends, and challenges, led by Jane Dimit Champion, MA, FMP, AH, CNS, FAAN, FAAME, Professor, Director, Doctor of Nursing Practice Program. So welcome, Dr. Champion. Thanks for joining us.
Hello. Are you able to hear me okay?
Yes, Dr.
Yes,
Champion.
we hear you.
Oh, good. Thank you. Well, good morning. And it's the first time I'm introduced to your group. And there's one of my colleagues, Maria Saldiva from UDL in San Antonio. Is indeed a small world. Anyway, I'm thrilled, very happy to be here and privileged to have the invitation. I recognize all of the important and the outstanding institutions that are sponsoring this agenda. So thank you to them. What I'd like to do is, as concerns prescriptive authority with APRNs, advanced practice, and also with bachelors, talk a little bit about my experience and where I'm at now, how I got here. The reason I think this would be helpful is because my journey really represents the experience within the United States in terms of transitioning to a state, or the transition to a state in which we have all the states within the United States experiencing healthcare provided by advanced practice nurses who have prescriptive authority and have independent practice. As you know, a little over half of the states in the United States experience independent practice provided by advanced practice nurses. I began many years ago as an advanced practice nurse at a time in the US at which you were able to provide advanced practice with a bachelor's degree. That was in the 70s. I got my training with a master's as a clinical nurse specialist initially, and worked in the hospital, in adult health, and in the community. And then I transitioned to psychiatric mental health as a clinical nurse specialist, which, as you know, at that time, clinical nurse specialists were not able to prescribe. Okay. So I was not able to prescribe, and instead was in a situation in which I was able to provide care. I quickly realized that the opportunity to provide care was extremely restricted by the absence of the ability to prescribe. You can only, perhaps in many situations, provide a smaller or much smaller percentage of the care that is needed for a patient. So I became a family nurse practitioner because I realized that in order to provide the care and the kind of care, the scope that I wanted to and felt was necessary, that I needed to be able to prescribe. And as you know, nurse practitioners and the initiation of a form of advanced practice began in the 70s and primarily focused on rural areas and provision of care in rural areas. This was, I think, one of the most important things that are ways that advanced practice contributed to healthcare and continues to do so, is by providing care in underserved areas in the United States. And many of these are in rural areas where we have fewer physicians and other healthcare providers. So nurse practitioners in that role provided care, and it gave us a window to expand this kind of care, the advanced practice scope of practice to patients in other locations. And interestingly, now with the change in the demographics within the United States, you'll find that rural areas are much smaller, a much smaller percentage of the population in the United States. And so the care provided by advanced nurse practitioners is primarily within urban or metropolitan or suburban areas, mainly mainly metropolitan versus non-metropolitan areas. Now, that varies among the states, of course, in the United States, because there's such variability within the country in terms of geography, socioeconomic level, etc. And therein, you'll have differences in the disbursement or distribution of nurse practitioners across our country and within states. So that leads me to tell you about where I am. I am a professor at UT, University of Texas at Austin, and I have my PhD and my DMP. And so many years I spent working with research only, but I always kept my practice and my focus as a nurse practitioner. And to this day, I practice in a rural health clinic every week that is along the border for Texas and Mexico. I am about 50 miles anywhere you go, any direction, to go to the border. So it truly is a very rural area that I live in. This is one of the probably few remaining areas within the United States that has not, there aren't enough providers, and nurse practitioners make a huge difference. We see the majority of the patients here, and we provide their care. Texas is one of the remaining states in the United States that does not have full practice authority. So we still work under the delegation of a physician. And my goal as a nurse practitioner and as a doctor of nursing practice, my goal is to, before I finally retire, see that we have full practice authority and that my scope of practice and what I am allowed to do legally, you might say, is consistent with the way I practice. And I think that's one of the most important objectives of nurse practitioners in the United States, because we have great difficulty in providing care to patients unless we have full practice authority. The reason I believe this happens is because it introduces error if we are not able to have full practice authority, because we are seeing patients, but then we may or may not be able to prescribe a medication. And then we have to ask someone to help us learn more about if they think it's okay or not. And that introduces error. I believe in collaborative care. I believe in collaboration on every patient. However, being forced to, when your experience is perhaps more than the person who is overseeing you, is really non-productive. And so there's an element of discomfort within, I think, the APRN population, that profession, with this supervision of care. And I can give you an example. If a physician graduates from medical school, then I've been practicing for, I think maybe 40 years. And that person is monitoring, my care. So I see that it doesn't make sense, and that we have a real need to change this so that nurse practitioners can have a fuller scope of practice and are able to prescribe completely as needed for patients. I realize in some countries that prescriptions, you don't really need them for everything. Of course, you're able to obtain it quite easily, but still, in terms of practice, I think it's extremely important to have the ability to prescribe, because you just are limiting yourself. There are many limitations, as we know, in trying to accomplish advanced practice without the ability to prescribe. Even with psychiatric mental health, when you do counseling, I did counseling, but was not allowed or able to prescribe. So it limits what you are able to do and how you can contribute to a community. So I think it's extremely important that that objective is accomplished. Therein lies concern by much of the globally and by much of the healthcare profession that nurse practitioners would be competent, or advanced practice nurses be competent in care and the care they provide. And I think this is one of the greatest challenges that we as advanced practice providers in the United States face. We have found that one of the strongest arguments against expansion of the scope of practice and the ability to prescribe, the arguments are that there is not competency. And in some cases, this is probably true. There can be such a variability in terms of the academic preparation of students, both didactic and clinically. And this is a grave concern in the US. And I think all of you would understand globally, it's always a concern. So one of the challenges we have is to develop curricula and to develop faculty within these programs that have the expertise and have the competence to develop a student that can represent and provide the quality of care that attests to the contribution that advanced practice nurses can make and do make to healthcare. One of the most important concerns I have, and this is my opinion, my concern is we've developed and expanded the role of advanced practice nurses in the US to such a degree that there are many, many students who want to attend. However, we don't have the faculty to attend the programs, to teach. This leads to the inclusion of less experienced faculty, curriculum that are programs that are becoming shorter and shorter to allow more students in and to allow the program to have adequate faculty. The next problem, we do not have always adequate space. Individuals need to be able to learn in an environment that represents what they will be experiencing in the communities. These programs, we have so many that the clinical settings are extremely limited in what they can provide. This causes a dilemma in that we change hours for students, clinical hours, to accommodate the lack of clinical space and the need for an increased number of clinical hours to become an advanced practice nurse. So, what do I see? If I could recommend humbly, I would recommend that in the development of programs in the US and globally, the inclusion always of faculty who are practicing. It is too hard to teach students. How can they learn from those who are not practicing? The science, healthcare science is just advancing so rapidly that if I were not practicing for 1 year, I would have great difficulty finding a way to move back into that program and be able to know. And So I think if I could recommend, I recommend that you want to have people who are practicing and seeing patients. Now, I think there was a comment, which is a really good one. It's not all about prescriptions, and I totally agree. It's not. It isn't. Probably 60% of what I do in the rural health clinic for primary care has a psychiatric or psych component. Yeah. I mean, it's about people and taking time and learning about them. Totally agree. But if you limit the scope of practice by not allowing the potential and the possibility to provide medication when needed, you might end up actually impeding the care that you can provide. So I think it's a good point, and I agree. I think it's necessary to be able to have that capacity to prescribe when it is needed. We find that every patient, everyone is not an individual. Each case is not one that would need a prescription, but you want to be able to have that capacity. And that provides you a scope of practice such that you're able to provide more comprehensive care. I think I practiced for many years without the ability to prescribe. And so I understand that. I did it for many years. But I also realize that in a place or in a community in which you have limited health care, if you have advanced practice nurses there and they have the ability to prescribe, then they can provide more comprehensive care. Last thing, I believe that people can have the option. Everyone who is an advanced practice nurse, every one of those, you don't have to prescribe if you don't want to. But I'm talking about having the capacity and the ability to do it allows you to provide more comprehensive care to people, to a community. It's something that allows a broader scope of care to be able to, I think, to attend to the needs of an underserved community. So one of the changes, I think, that has occurred since more of the rural population has moved to urban, non-rural areas, is that the nurse practitioners or APRNs are focused in these settings. The majority of them are working in urban areas. And this leads to the need for more specialization as a nurse practitioner, which is probably helpful. So I think that I was reading the message. So I think that the move to have more specialization for nurse practitioners is good, because with that, you're able to focus on a specific area and be more knowledgeable. Physicians, many years ago, realize the need to specialize because of the broad expanse of knowledge and information that one needs to provide healthcare. They realize that. And now, as nurse practitioners or advanced practice nurses are focused in urban areas, I think the need also is present for them to specialize, because you're going to have a better idea about the trends in terms of care, the need to provide care in a specialty area. I think that's important. So in many places, in many countries, I believe that there is a need for a broader scope for nurses to provide primary care with an option. You should, I think, if you can show that you have that capacity and that you can competently provide care, I think it's an important contribution that can be made globally for healthcare. So, yeah. And then there's one other point that I wanted to make a comment. You know, in the U.S., and for those who are developing programs, we have a doctor of nursing practice, as you know, and it's for a nurse practitioner or an advanced practice nurse to become a doctor in nursing practice is what is intended to be the ultimate or the degree for those who are interested or want to practice as advanced practice nurses. There has been some difficulty in terms of transition. It's hard to transition from one form of care or one level of education to another level. And that's tough. And I think we're working on that in the US. It was meant to provide more education because there's just more out there, more clinical hours to develop more competence before individuals, go into practice. So we're transitioning to meet the need for more clinical hours and to develop greater competency, perceived and real, okay, for nurse practitioners. So that's all I have really. I want to just emphasize that I did practice many years without prescriptive, authority. And I just find personally, and I think that it's made an impact, because out here where I'm at in the rural area, we just wouldn't have care, So I think it's important to have that and to have that capacity. And again, it's not for everyone. Everyone doesn't want to do that. And I think some opposition typically is felt to this, and that's normal. It's not for everyone, but I think make it available as an option so that people can be provided more comprehensive care when needed. Okay. Not everybody needs it. Yeah. And I agree with caring as a paradigm. Absolutely. One of your distinguished colleagues who's from Colombia, Daniel Suarez Baquero, he did a concept analysis of caring and really helped me learn a lot. Not enough, but I learned a lot about the conceptualization of nursing and caring in Colombia, and also I believe in it in the US. But it can include, in my opinion, this other component can be built into it. And perhaps that's a paper or something to discuss. All right. Does anyone have any questions?
Thank you, Dr. Champion, for this talk. We think it's a real important subject for nursing right now, mostly for low and middle income countries, because we have a lot of population in rural areas, and we need to develop the autonomy and the authority of nursing to prescribe medications.
Yes. Can I respond to a question?
Yes.
Oh, thank you. So there's the question about what kinds of medications can we prescribe. I think that's important. We are limited. We can prescribe in primary care antibiotics, medications for depression, for hypertension, for all the comorbidities, for chronic disease. What we cannot prescribe is like, if Maria's there, she can chime in. Stimulants, for example, Adderall, we can't give that. We can prescribe Valium. We don't much, of course, but we can prescribe some pain medications, but we're limited in that capacity.
Yeah, certain controlled substances like narcotics.
Yeah.
Certain narcotics we can't prescribe.
Yeah.
So thank you so much, Dr. Dini.
Sure.
We have only a few minutes. We want to ask you for an advices from countries that are raising the advanced practice nursing about this area of authority to prescribe. What advices have you to us, please?
You're asking me what advice?
Yes.
Oh, yes. I think pursue it. You have to start probably smaller, but I think in Spain they started maybe bigger and just began, allowing nurses to practice. But I think you can make a huge contribution to areas in which are communities in which healthcare is limited. You may have to start smaller, but you can progress to expand your scope by learning what you can do first. Figure out, okay, what works? What can we provide? And then expand the scope. I wouldn't recommend going in and just bam, doing everything at once, because you don't know exactly what would work for a community and how people respond. One thing what I would recommend is that along the way, measure your outcomes, measure the outcomes of the care, figure out a way to be able to know what the impact of your care is giving. Finally, after so many years, we have outcomes. They show that nurse practitioners do not prescribe more than physicians. They prescribe consistently the same medications as a physician would or a PA. Outcomes with pregnancies, you can just go the whole deal. It doesn't have to be about prescriptions initially, but you can fill it in and see. Make sure you measure it so you have proof. You need evidence really to document and to provide evidence to your governments to show that it can work, the things that this kind of role is important. Get feedback from the communities, the patients. Let them tell you what they want, because what might work in ours country, obviously, we know doesn't work so well in others. So it has to be modified. So measure. Don't start huge, big, start small, build it. Find out from one community what they like and expand. Yeah, and measure. I think we go in and we do things and change it, but we don't have a baseline. Get your baseline data so that you can show change, because you will be challenged and you want to be able to document. If something's not working, you want to change it, So document.
Thank you. Thank you so much, Dr. Champion.
Sure.
We will. So we are going to move for the second part of our agenda. Thank you,
Yeah.
Dr. Champion.
Thank you.
Please keep in touch. Thank you.
Oh.
And we are going to turn the word to Juan José. Juan José, adelante.
Okay, now, so thank you, Dr. Champion. So at this point, the presenters will have 10 minutes for each presentation. When your time is almost up, I will tell you by Zoom. Okay. So from Brazil, Dr. Luciana Gonçalves, Professor Director Daniela Soldera, first Doctor of Nursing Practice in Brazil. In this case, Luciana couldn't be here today, but she has sent us a video. Oh no!
Yes, she is also here, but she sent us a video. Daniela and Luciana, welcome.
Olá, bom dia. Meu nome é Daniela Soldeira, sou enfermeira, docente do Programa de Pós-Graduação Prática do Cuidado em Saúde da Universidade Federal do Paraná e também sou a primeira doutora profissional do Brasil pelo Programa de Pós-Graduação em Gestão do Cuidado e Enfermagem da Universidade Federal de Santa Catarina, Brasil. Eu destaco como objetivo do doutorado profissional a capacitação de enfermeiros a partir do desenvolvimento de habilidades analíticas, críticas e transformadoras para a sua prática assistencial, além de instrumentalizá-los para participar na reorientação e ou fortalecimento de políticas públicas e práticas de enfermagem e saúde. Os programas de pós-graduação na modalidade profissional visam resolver desafios encontrados pelos enfermeiros através da geração de inovações e de novos conhecimentos, contribuindo assim para elevar os padrões da profissão da enfermagem brasileira, bem como promover o aprimoramento da prática assistencial para a excelência no cuidado. Em relação às práticas avançadas em enfermagem, diversos desafios se apresentam, sobretudo no âmbito regulatório, considerando as particularidades do sistema de saúde brasileiro, que continuam a fortalecer a hegemonia médica em sua estrutura. Neste contexto, foi elaborado por comissão e submetido ao plenário conceitos, ações, implementação e regulação das práticas avançadas em enfermagem, que já são uma realidade em grande parte do mundo, como nas Américas, existindo há mais de 60 anos. Esses profissionais têm desempenhado importante papel no acesso da população ao sistema de saúde, bem como na assistência direta ao usuário. A América Latina é a única região do mundo que não conta com essa necessária força de trabalho. É relevante destacar que a conscientização sobre a importância da prática avançada em enfermagem está em ascensão no Brasil, impulsionada pela necessidade de ampliar o acesso aos cuidados de saúde e aprimorar a utilização eficiente dos recursos disponíveis, uma vez que o Brasil detém as condições favoráveis para implementar a prática avançada de enfermagem, pois acumula as qualificações necessárias para atender aos padrões preconizados, como a liderança nos programas de pós-graduação em enfermagem, um sistema de saúde nacional com o programa de saúde da família bem constituído, equipe interprofissional e decisão política de ampliar o acesso e a cobertura universal dos usuários do sistema de saúde, promovendo a melhoria das condições de saúde, principalmente da população vivendo em situações de vulnerabilidade e áreas remotas e desatendidas. Nesse sentido, os enfermeiros buscam aprimorar suas habilidades por meio de especializações de forma a atender às demandas crescentes, sobretudo na atenção primária à saúde, onde as práticas avançadas em enfermagem influenciam diretamente na autonomia e na amplitude das funções que estes profissionais podem exercer, dentre elas a prescrição de medicamentos, de exames laboratoriais, exames de imagem e diagnósticos, que são respaldados por protocolos bem delineados. Em relação à prescrição de medicamentos pelos enfermeiros no Brasil, estes enfrentam alguns desafios, mesmo após a aprovação por unanimidade de um parecer do Conselho Federal de Enfermagem em junho deste ano, que assegura a competência e dá respaldo aos enfermeiros para a prescrição de medicamentos, em consonância com os programas de saúde pública e procedimentos aprovados pelas instituições de saúde, por meio de protocolos alinhados às diretrizes condicionadas pelo Conselho Federal de Enfermagem e pelos respectivos Conselhos Regionais de Enfermagem. Estes órgãos são responsáveis pela elaboração de protocolos que não apenas regulamentam a prescrição de medicamentos na atenção primária à saúde, mas também visam a redução de falhas, garantindo assim a segurança do paciente. Enfatiza-se que, em alguns estados brasileiros, a prescrição de medicamentos na atenção primária à saúde está consolidada há alguns anos, como exemplo o estado de Santa Catarina. Porém, em regiões remotas do Brasil, principalmente estados da região norte e demais municípios no interior do país, diversas perspectivas em relação à autonomia das ações dos enfermeiros, principalmente no que se refere à prescrição de medicamentos, ainda precisam ser consolidadas pelos respectivos conselhos regionais de enfermagem. Outro desafio importante encontrado pelos enfermeiros da atenção primária à saúde em relação à prescrição de medicamento se dá quanto à aceitação dessa receita pelas farmácias para a retirada de medicamentos de uso contínuo ou não, fornecidos pela Farmácia Popular do Brasil. Embora a prescrição seja reconhecida e respaldada pela legislação, em muitos municípios, a retirada dos medicamentos ainda está vinculada à apresentação de receita médica ou odontológica válida. A concretização do pleno direito do enfermeiro em relação à aceitação da prescrição de medicamentos nas farmácias comerciais, bem como nas farmácias do Programa Popular do Brasil, irá beneficiar diretamente a população atendida no Sistema Único de Saúde, ao mesmo tempo em que garantirá a autonomia profissional, muitas vezes prejudicada por essa recusa. A prescrição de medicamento pelos enfermeiros é uma prática em constante evolução no Brasil. É fundamental que as regulamentações sejam claras, as competências sejam bem definidas, uma vez que o cenário futuro pode incluir uma maior integração de enfermeiros na tomada de decisão, relacionadas ao uso de medicamentos, com foco contínuo na melhoria da qualidade do cuidado prestado à população. As tendências indicam uma expansão possível das competências dos enfermeiros, incluindo a prescrição de medicamentos de forma mais abrangente, alinhada ao seu papel como profissional de saúde, apoiados em protocolos implementados pelos seus respectivos conselhos regionais de enfermagem de cada estado brasileiro. Muito obrigada. Olá, bom dia. Meu nome
Juan José?
Sorry. Thank you very much. So, thank you, Dr. Luciana and Daniela Solter. So now we are gonna continue with Japan. So from Japan, Professor Kyoko Surga.
Thank you, Juan Jose. I'm going to share my screen with the presentation for Dr. Suga.
須賀先生、頑張ってください。
Okay. Hi.
Hi, doctor. Let me open the presentation. Can you see my screen?
Yes.
Thank you. Can you hear me?
Yes, doctor, we can.
Good morning and good evening. It's about 10:30 p.m. in Japan. It's very nice to see you all. I'm Kyoko Suga, professor and director of the Department of Nursing. Nursing School of Health Sciences, Asahi University, Japan. Today, I would like to make a presentation on nurse practitioner education in Japan for a better healthcare system and QOL for patients. Next, please. This shows the characteristics of Japanese society. Japan is a super aging society, and by 2040, health needs will be higher than ever. Then there is a high prevalence of chronic disease, underserved remote areas, and disaster-prone society. Next, please. According to 2020 data, Japan has about 340,000 physicians and 1.28 million nurses. There are 269 physicians and 1,015 nurses per 100,000 population. Almost 30% of physicians are 60 years old or older. Next, please. I would like to describe the development of education and regulations for nurse practitioner in Japan. In Japan, nurse practitioner doesn't yet exist as a national certification. Currently, 2 organizations have nurse practitioner education programs. The Japanese Organization of Nurse Practitioner Faculties, JONPF, was established in 2009 to support activities that lead to a high-quality NP education. In 2022, 18 graduate schools are members. JONFP researches about the expanded roles of NP and promotes understanding of NP roles in the Japanese society. Next, please. The first NP education program in Japan was established at Oita University of Nursing and Health Sciences in 2008. JONPF proposed NP education in Japan, curricular contents and number of credits in 2010, but NP has been institutionalized in Japan. And the following year, the first NP certification exam was implemented by JONPF. At this point, there was still no unified view among physicians and nurses on the institutionalization of nurse practitioners. In 2014, a law that established the training system for nurses who can perform specified medical acts was passed, but this doesn't refer to nurse practitioners. Meanwhile, the Japan Association of Nursing Programs in Universities, JAMPU, also began its own NP education program in 2015. In 2020, the Japanese Nursing Association, JNA, and JO and JAMPU and JAMPU, JONPF and JAMPU agreed to work together to build up a nurse practitioner system that meets international standards. And a written petition regarding the establishment of an NP system was submitted to the Liberal Democratic Party of Japan. Next, please. This is the outline of standards of specified medical acts and training for nurses. After attending training in specified medical acts, nurses will be able to perform specified acts in accordance with the procedures, guidelines, and manuals. Next, please. NP education at the master level has theoretical and practical components. Nurses who have other degrees or possess practical skills are exempt from some courses. Next, please. This figure shows an image before and after training of nurses in specified medical acts. Normally, the nurse reports to the physician each time and receives instructions to perform medical procedures. But after training, nurses might perform specified medical acts in a timely manner within the limits indicated in the procedure manual. Next, please. Specific acts are following 38 acts which are assisting in medical treatment and require practical comprehension, critical thinking, and clinical judgment, and advanced and specialized knowledge and skills when performed according to procedure manuals. Next, please. This is the NP education program that was proposed in 2014. It consists of 315 hours of common required subjects and 72 hours of categorized subjects, and nurses will be evaluated for mastering levels and completion. Next, please. This is the position of the Japan Nursing Association. 1. Currently, there is no nurse practitioner certification in Japan. 2. Education programs preparing Japanese nurse practitioners, JNP, may be up to international standards. However, NP in the US and other countries are certified to conduct diagnosis and treatment independently and without receiving physician's indications. 3. Nurses in Japan are legally compelled to receive physician's indications to conduct medical acts. In addition, at the moment, they cannot diagnose nor prescribe medications. 4. JNA, JAMPU, and JONFP are working together to establish a nurse practitioner system that meets the future health needs of Japan. Thank you for your kind attention. Thank you.
Thank you. Thank you.
Okay, thank you very much, Professor Suga. Now from Turkey, it's the Associated Professor Demet İnengil. Professor İnengil, thank you very much for joining us.
Thank you.
Can I share my presentation or?
We have your presentation. I'm going to share my screen, Doctor.
Thank you.
Can you see my screen?
Yes, I can.
Okay.
I can't move now. Other slides. Can you progress or?
No, I'm going to progress for you.
Progress. Okay, thank you. Hello to everyone and my colleagues. I'm very happy to be here with you. I'm Demet İnangil from University of Health Sciences, Hamidiye Faculty of Nursing, Istanbul, Turkey. Thank you for this amazing organization and kind invitation. I would like to talk about, yes, can you pass? Our context is like this. According to our topics questions, do nurses have medication prescription authority in our country? And if so, and this regulation, legislation, and training and education, I would like to talk about this topic. You can pass, yes. Actually, we don't have the authority medication prescriptions. But I would like to talk about the current status and challenge, and are we ready in shortly? Are we ready for medication prescription? Yes. We have 4-year undergraduate, master's, and doctoral programs since 1955. And these programs include physiopathology and pharmacology courses. But there are not yet courses such as advanced pharmacology that will provide medication prescribing competence. We have master degree programs, as you know, medical, surgical, fundamental of nursing, pediatric, women's health, and so on. We have PhD program, but we don't have the DNP program. There are no defined PRN nurse practitioners in our country. And the legal regulations for prescribed medication are significant to us. Physicians in Turkey work under the first law in 1928, law on the style of performance of tababat and şöbeti arts. And according to this law, the authority to prescribe is determined and given to doctors and dentists only. And the first draft law was issued in 1980 regarding nurses prescribing medication, but it was not valid today. Apart from this, the current law gave us powers within the scope of medication treatment and health assessment, and like this. And the last one in 2016, the government announced that it will study the nurses' authority to prescribe medication. This was good news for us. And Turkish Nurses Association is working still ongoing regarding these topics. And what do nurses think about this? The other slides, we can say we think that as a nurse, the primary roles of us is caregiver, but also prescribed medication will give us competence and autonomy. Also, it's necessary to determine the criteria well and structure a good training. And in short, we think that we are sufficient in terms of education and clinical experience in this regard. However, legal regulations restrict us. Thank you for listening. I hope the legal regulation will be complete as soon as possible and we will have competence in this regard. Thank you for your listening.
Thank you very much, Professor Inengi. Thank
you.
Now, continuing from Thailand, it's Assistant Professor Dr. Ransi Yanari, Public Health Nursing Department. So, Dr. Nari.
Yes, I'm here.
Thank you.
All right, someone will flip the slide for me, right? Okay, thank you, Sonia. Okay, everyone, I would like to talking about the current status and challenges about medication prescription in Thailand. So I'm Francia Narin from Faculty of Nursing, Chiang Mai University. Next slide, please. So this is the contents that I would like to share today. Next slide, please. Next slide, please. So in Thailand, if you ask about authority, about medication prescription, generally in the previous time, physician or doctor is the main highest degree to prescribe authority of medication. Next slide. But now in Thailand, next slide, please. Now in Thailand, as in the previous time, the nurse, especially the nurse who work in the rural area, they have been provided primary medical care, and their work at that time is considered illegal. But up until 1996, the Ministry of Public Health, or MOPH, has set the regulation to authorize the nurses and other healthcare personnel to treat minor illness and prescribe some medication under authorization of the physician. And then after the national reform and universal coverage system implemented in 2002, and then after that, we would like to serve about a shortage in the medication practitioner who work in the community. So that's why the TNMC, or Thailand Nursing and Midwifery Council, they plan to increase the number of nurse practitioners and a registered nurse who generally engage in primary medical care in all health promotion settings in the community. Next, please. So at that time, we have a nurse practitioner who trained. Sorry, next slide, please. So at that time, the nurse practitioner, they have authority to prescribe medication for the primary medical care at the community level. So as we mentioned about the policy, the Thai government also created a policy to work toward the provision of the nurse practitioner at that time. To support this policy, we have a training and education in two ways. For the nurse practitioner, we have a short training course for 4 months program for the registered nurse who become a general nurse practitioner, or GNP, in particular primary medical care. And another way is advanced community nurse practitioner, ACNP, to prepare at the master level. And all of this we develop to work at the primary care setting. Next slide, please. So next slide, please. If you're looking at this slide, you can see that even we have a lot of nurse practitioners coming up in Thailand, but just only 2 of nurse practitioners who can prescribe or practice in access and prescribe medication. For example, general nurse practitioner in Chiang Mai University, we have the 26th batch of our training program and now we are in progress in the Chiang Mai University. And another way is community health nurse practitioner that they can train in the master level at the university as well. Next slide, please. And not just only that, at this moment, we revise or revision the curriculum about nursing curriculum. So at this moment, we have a nursing curriculum designed to provide students with knowledge and skill that necessary for the safe administration of medication. So if you're looking at the bachelor degree program, we have 3 credit course, or around 45 hours in pharmacology. And also we're teaching to integrate across the both theoretical and practical components of nursing course. So it means that we develop the nursing curriculum that related to the regulation of the TNMC. Next slide, please. And for the nurse who train as the administer medication, we can have like 17 different drug category. So it means we have allowed 52 medication to the patient under the provision diagnosis and basic treatment within the scope defined by the TNMC professional law and regulation. For example, the Faculty of Nursing Chiang Mai University, we have two courses like primary medical care 2 credit course and primary medical care practice around 2 credit course, around 120 hours course. So all of these courses, we also have rational drug use that adding up in the contents of this course as well. And for the practice, the student also practice in to how to writing up or prescribe the medication. Next slide, please. At the advanced practice level, as Dr. Jan, Professor Jan mentioned in this beginning, so the NP also have the 4th credit course about the general nurse practitioner, in particular primary medical care, basic disease treatment. This also involves the health assessment, medical history, physical examination, disease diagnosis, and treatment with prescription. Next slide, please. So as you know that we have a lot of articulation between the pharmacist and doctor and the nurse. Next slide, please. Even we have the legal, but the regulation or registration in Thailand, we also revise many times. For example, the revision that we have in 2018. Next slide, please. So once we have the what we call the conflict together with the pharmacist, doctor, and the nurse, the TNMC also take the action, make announcement about the prescription, a list of medication, and diagnostic for professional nurse and practical nurse in basic disease treatment from last year. So they're talking about the medical acts that they revision together with the collaboration with the other health profession. Next, please. Next, please. In this declaration and announcement, they also point out the role and responsibility of the nurse practitioner and also the course and curriculum that the nurse need to prepare for medication safety and also prescription with the medication. Next, please. And if you ask about guideline and protocol to prescribe medication, the TNMC also revised the guideline and protocol and the what we call the drug list for medication and diagnosis agent for the nurse. For example, they give very clear about the nurse who have not completed specialized training, so they have to prescribe the medication as the symptom and disease in 33 categories. Next slide, please. So this is the list of 17 groups of medication and a list of 52 medication. Yes, next slide, please. And for the nurse practitioner, so you can see that they have more scope of the drug list of medication and diagnosis agent for the nurse practitioner. Next slide, please. So if you're looking here, the number 18 for the medication, for example, antihypertensive drug or anti-diabetic medication. So the nurse practitioner can refill this medication as a doctor prescribed, but other may be the same of other country. Next slide, please. So this is the current status and challenge in the future in Thailand. As I mentioned, we have a lot of interpersonal collaboration that we need to go to work more, and also continuing education for the nurse and nurse practitioner. And maybe we need to thinking about online pharmacy that coming up in the future, and RDU or regional that use that we need to add up in all the nurse level. Thank you. Yes.
Thanks a lot, Dr. Narin. What an interesting intervention. So let's continue from United States. Susan McDonald, PhD, APRN, CPMPC, Associate Professor, Cuidando. So welcome and thank
you. Sorry, Juan. Dr. McDonald, I received your presentation, but I can't open it. Can you share your presentation in your screen, please? Your mic is off.
My computer has been interesting.
Don't worry, doctor.
Don't worry, doctor. So let me share my screen. Okay, so you have to enable me.
Please listen.
Okay, let me see.
Hey, boy. You
Yes.
can share your screen now, Dr. McDonald. Okay, yeah.
Thank you. Okay, let me share my screen. Great. Show from beginning. Okay, so I'm have the pleasure of discussing prescribing practices for APRNs in the United States. And Dr. Champion gave a very, very good overview of what the current state is. So I'm going to kind of go through what I put together. So APRNs, Advanced Practice Registered Nurses, in the United States, there's 4 different specialties under that umbrella. The nurse practitioner, which is common to many of you, the clinical nurse specialist, who's primarily an inpatient advanced practice nurse, the certified nurse midwives, who provide obstetric and gynecologic care to women in reproductive, for reproductive health, and then the certified registered nurse anesthetists. So there are requirements for the preparation of advanced practice registered nurses across those 4 specialties. First, you have to be an RN with a Bachelor of Science degree. You have to be licensed as an RN, and you have to have 3 core courses as part of the basic curriculum. The 3 Ps, as we call them: advanced health assessment, advanced pathophysiology, and advanced pharmacology. And then there are specialty-focused didactic and clinical courses that must be completed. Also, in addition to those courses, there's leadership, health policy, research, and a course that focuses on the APRN role. So in the United States, there is a national certification requirement for nurse practitioners. 48 out of 50 states require specialty certification to be recognized as a nurse practitioner in their state. However, they're all third-party insurers, including the national insurance for retired people, Medicare, require NPs to be certified. Thus, everyone needs to be certified to practice as a advanced practice nurse who's going to be prescribing. There are continuing education requirements. These vary from state to state. The requirements are set forth by the certification organizations as well, and then states and certification organizations do require pharmacology continuing education hours for prescribers. So in the United States, we have 50 states, which means we have 50 sets of regulations, which can be pretty frustrating if you live in one state that's full practice and you move to another state that has reduced or restrictive practice. This is a map that just shows you which states have full practice, reduced practice, and restricted practice. And I'm going to go into what exactly these mean. Full practice is a state where nurses are permitted to diagnose, interpret diagnostic tests, initiate managed treatment, prescribe medications, including controlled substances, under their own license authority, and they're under the Board of Nursing in their state. And this model is recommended by the National Academy of Medicine, formerly called the Institute of Medicine, and the National Council of State Boards of Nursing. Reduced practice, there's still some collaboration that's required with physicians. It's a little bit more restrictive in the fact that you have to have a certain amount of charts reviewed, but it's not as strict as the restrictive practice states, which I live in. I live in Texas as well. And we have to have monthly meetings with our collaborating physician, and it's career-long supervision. So it isn't like a temporary thing where they're like, yes, you're safe to practice. And then what happens is, they trust you to do what you need to do. Ours is career long. We always have to have a collaborating physician. What happens in the United States as well is that we have advocates for us in the various states. So the advocates that we do have are, of course, our professional nursing organizations, as well as our as people that are consumers of healthcare, and they have been advocating for us in the various legislatures, because we have to look at both the state and the federal level as far as getting legislation passed to get full prescriptive privileges and full practice privileges in the United States. So that's basically my presentation. I don't want to repeat everything Dr. Champion said, and I thank you for your time and attention.
Dr. McDonald, thank you so much for the presentation. It was so interesting. So, and now from Chile, Dr. Francisca Marquez.
Dr. Marquez?
Yes, I'm here.
Welcome, Dr. Marquez. I want to tell us that Dr. Marquez is the first time of Chile in this meeting. I want to welcome you, Dr. Marquez. Dr. Marquez works in the Pontificia Universidad Católica de Chile, that is a referent for the best education and practices in nursing, and is the first program in our region that offer the advanced practice nurse profile. Welcome, Dr. Marquez.
Thank you, Sonia. I would like to say hello to everyone. I introduce my presentation about medication prescription and the current state in Chile. My name is, as Professor Sonia said, Francisca Marquez Doren, and I'm a professor at the School of Nursing at the Pontificia Universidad Católica de Chile, and I'm also the Director of Postgraduate Studies. First of all, I would like to introduce to you some background information about Chile. We are a country located in the south and extreme south of the American continent, with around 19 million inhabitants and the capital is Santiago, which is located in the center of the country and has about 7 million inhabitants. The first three main causes of death are cardiovascular diseases, cancer, and respiratory system disease. with a significant increase in chronic non-communicable diseases in the population, and we have an important population in need of opportunities of specific care, especially in areas like rural and undeserved ones areas. This is the School of Nursing at the Pontificia Universidad Católica de Chile, and this, the main entrance at the Campus San Joaquín. And for the question that the organization sent to us, I would like to say that if we have a medication prescription authority in nursing, and the answer is no. However, nurses in Chile are regulated like other health professionals by the sanitary code. The sanitary code empowers physicians and dentists with the authority to prescribe. However, they can delegate such actions in cases that are not present or there is a specific situation regulated by the services. In such cases, the nurses may prescribe medication. Also, advanced practice nurses training program were launched in the country in 2021, considering an extended role that allows them to prescribe drugs supported by protocols. For these cases, prescribing possibilities are being regulated and are under development. There are regulations at the health services level that allow services chiefs to empower nurses to prescribe medication in specific cases through the use of clinical guidelines and protocols. For example, anticoagulant treatment or modification of treatment in people with chronic conditions such as hypertension or diabetes. We have guidelines and protocols, clinical guidelines for the indication of medication and modifications of specific dosages, as is the case for treatment with anticoagulants, as I mentioned previously. Specifically, in the case of advanced practice nurses, they have specific action protocols that had been created for joint work with physicians where responsibilities have been separated to truly improve access and coverage. And what are the training and education requirements for nurses prescribing medication? In our country, for nurses to practice in a specialty area that allows them to prescribe specific medication, they require at least 1 year of specialty training and training as advanced practice nurse. In the latter training program, they receive specific training in pharmacology, as well in pathophysiology and physical assessment, and to be able to diagnose, treat, and follow up people with acute and chronic conditions who are stable. In Chile at the moment, we have programs that train advanced practice nurses with a specialization in oncology and palliative care. We are developing a specialization in family and community health. And what barriers and facilitators do we have to prescribe medications? Facilitators include the recent incorporation of the advanced practice nurse practitioner role to the country and the potential to improve access and coverage possibility in different areas. As barriers, there is the performance of a new role that is not so widespread and that generates certain fears regarding the delegation of responsibilities such as prescribing medication. There are also barriers from the nurses themselves who do not want a role to be developed that could bring them closer to the medical profession and move away from what is properly nursing. The main challenges faced by nurses in prescribing drugs is to have the necessary regulation according to the level of training that allows them to practice with the necessary safeguards. In the current role, the prescriptive function of nurses is articulated with the medical function and duly safeguarded in a delegate action. Also, I came here with this new, so you can know about the colloquium that we have in Chile between 4th and 8th of November, 2024. Thank you very much much for your attention.
Okay, thank you very much, Dr. Marquez, for this interview.
Thank you, Dr. Marquez. Sorry, Juan Jose. We have a crowded agenda today. I know that our Japanese colleagues are in a very deeper night. So please put your questions in the chat, and I encourage you to put your contact information and to answer the questions by chat. Go ahead, Juan Jose.
Thank you, Professor. So now from Colombia, BSN Lina. So welcome.
Thank you so much, Juan. Professor, I don't know, Juan or Professor Sonia, could you please share the presentation? Thank you so much. Well, thank you. And following with the last presentation of this session, if I'm not wrong. So next slide, please.
I'm sorry, Lina. Let me check my I don't know why.
It's okay. I think that you have to scroll down.
Yeah.
So if you can minimize the size of the
Yes.
window,
I'm sorry. Let me check my computer.
Take your time.
Wow. I know many of those people on those photos, by the way.
Yes, while I checking my computer, please, Christian David wants the people open your cameras to have a photograph.
It's beautiful. I think I know the entire team of the Columbia University now.
Time to visit, Sensei.
Yeah, Lorena, I really want to go.
Okay, Lina.
Daniel.
The time is great, by the way. I'm checking the timer, Dana. Don't worry, I have the timer with me.
Go ahead, Lina.
Okay. So this is the Colombian team. We are going to begin with the prescriptive authority in Colombian nurses, what is our current state. So first, nursing is the liberal and autonomous profession, and it's well defined in the Colombian law. So the profession have the authority to prescribe direct care, but excluding medication. So the main goal is to promote health, prevent diseases, and actively engage in treatment, rehabilitation, and recovery. And all of these things is going to alleviate pain and contribute to a dignified life. So we have a work right now based on the interdisciplinary and multi-professional and transdisciplinary dynamics. And we are not just working right now in the traditional areas, but also in places where individuals live, work, study, and recreate. So the administration of medications, for nurses, we have to get the adherence. It's mandatory to have that adherence to proper protocols and a valid medical prescription. So we can do that. We are covered by these two laws that you can see in the bottom of the slide that are really important for us. Next slide, please. So, we have three main points. The context in our country is that we can provide autonomy and direct care, but we lack the authority to prescribe medication. So this role is just limited to administration of medication with the mandatory regulations. Also, the system that we have in Colombia it's primarily based in insurance. So we have a centralized healthcare system in major cities, and is obviously like specialized in areas like oncology, palliative care, cardiology, surgery, like the main ones. And we have a challenge in the rural area because we have a rural and dispersed rural areas in which we have like approximately 13 million people that lack of that access to health service, prescription, medications. So I just recently read that 90% of the healthcare system is in the larger cities, and just obviously the rest 10% is the attention the health professionals and the health service that we can provide in the rural area. So it's a big challenge that we have like to improve. Next slide. So what is happening right now in Colombia? We are facing right now a new healthcare model, a huge change of the all main healthcare system. So the characteristics of this new system or healthcare model, it's in three key points. So preventive, predictive, and resolutive. And what is going on in here? So preventive, like that care, it's a comprehensive one across all levels and want to address the health of individuals, families, and communities. And the focus, it will be like on minimizing burden of disease, being proactive and preventive on the measures that we can have well with the population. In the predictive session or stage, we want to generate hypotheses predicting outcomes and anticipating, obviously, that future health events, how we can perform like early interventions and early care strategies. And for the last one, that is resolutive, obviously will be like giving a comprehensive and effective response for individuals and collective health needs. And what we want to do here is like not only like address the current health issues, but also contribute to long-term health and well-being of the population. And obviously, this is like thinking in the rural area, because we have a good health service in the cities, but we have a poor system access in the rural area. So next one, please. Well, right now, so what is the role of nursing in this framework of a healthcare model of resolution? So we have two main points: benefits of that nursing prescription that like in the future now. So, and also the required prescription for care interventions. For the second one, like obviously prescribing some care in the nursing area requires the authority. I mean, the prescription of medication. So that prevention and early detection programs like vitamin supplementation or palliative care settings, symptoms relief, and ER and pre-hospital care, like how we can work in that. And obviously the benefits for the second, for the first one, like the benefits of nursing prescription, what like how it can work in Colombia, like it will help to access and resolution needs in the rural area and dispersed population that like I was talking with Professor Sonia, like you have to walk 2-3 hours or going to the river for 4-6 hours to get into the community. So the nurse that is there, the nurse that is going to be there, how she can or he can answer and give that resolutive care. Also that that resolution of needs, like what the nurse can do close to their practice, also improve the quality and resolution of that care and the autonomy of nursing care. Like if there is no medical doctor, what I can do with my knowledge and analyzing the situation. Next one, please. Well, we have like the context in three three situations. Like right now, we don't have in Colombia nursing programs like advanced nursing programs like the ones that you have in the United States or Canada or UK. Like nursing practitioners, we don't have that, but we have master programs, but are not focused on gaining abilities like MPs. So for us, it's an historic moment where we like are aiming to have that possibility that BSN nurses must begin to prescribe and also gain experience and autonomy, and obviously learn how other countries are working in that and what we can do for like our Colombian situation. What are the competencies right now for the BSNs? We obviously can do the health promotion, disease prevention, integrated healthcare pathways like chronic conditions or diseases of public health concern. And also for the last one, education right now in pharmacology are centered that for the undergraduate programs, it's mandatory to have at least one basic course in pharmacology. So if you want to get like more knowledge, you can take it. You can enroll in this course through the elective courses now, or you also can have more information about pharmacology, like specific pharmacology in these disciplinary practice components like oncology, chronic disease, public health. So in each content on each practice clinical rotation, you are going to take pharmacology section for that situation. Next one, please. So the prescription models that in Colombia nurses use are divided like in 5. The first one is independent prescribing, like the autonomy that you have to give medication or decide like to put a device or perform a procedure. We don't do that. It's not performed here in Colombia. We don't have the legal authority to do that. The interdependent one, like prescribing in a complementary manner, we also don't have that. The third one, by protocol, we do that, but at a specific, like under that specific law, but it's just for diseases with prescription protocols, mainly on diseases of public health concern, like tuberculosis, leprosy, leishmania. But at the end, obviously, medical signature is required. The third one, it's prescription to administer. So in I wrote that right there, like advanced scenarios like CPR, stroke, allergies, seizure, like the main things, like critical ones in ICU or ER. So you as a nurse, you can give the prescription, or we are in this scenario, we are talking, give A or B milligrams of these things. You can do that at the moment. You don't need a prescription right there, but later on you will need a physician signature, like to have all the forms legalized, like I administered this and this and this, and it's everything signature, like everything's okay. And the last one, that is a prescription in time and dose. So there is like a prescription that is done by a medical professional, and you have, like, for example, that administration of analgesic in palliative care, focused here in Colombia, like in rescues. Like, so me as a nurse, I analyze and I say, like, the patient needs more analgesics, or how it's working, or I'm going to put a lower dose, or more of this medication. So that's the autonomy that we managed here in Colombia. Next one, please. So for the last slide, we're going to talk about the medication prescription by nurses, like what are the challenges that we are facing right now. So it's divided in 4 main key things. Like, it will be first the curriculum enhancement. So for nurses, like the BSN, the education that we are right now providing, we want to strengthen the physiology, pathology, semiology, and pharmacology abilities to enhance obviously that nursing curriculum. For the second one, that will be the training programs for advanced practice, like how we can design and offer a better training, and how we can do like benchmarking in the nursing, and why, like what we can take of another programs to like change our master degree programs, and how we can improve that master programs to like become, or like change that programs into a nursing practitioner ones. The third one will be the regulatory measures. So what we can do for like regulating the authority to allow prescription by nurses, and the prescription guidelines, like define the population and areas in which nurses can prescribe medications, and also include the list of medication and prescription requirements that nurses are going to use, and like have to take in mind, like be clear on that point. So that will be like the presentation that we have for you today. Thank you so much.
Thank you so much, Elena. Thank you so much, Juan Jose, for the moderation. And right now is the hour to take our photograph. Christian David is going to take the photograph. So please turn on your cameras.
Okay.
Well, that photograph is taken. Thank you so much, Colombia, for hosting this 13th Virtual Global Health Hub. And as per usual, you did an excellent job, excellent presentation, and it was very, very informative. I know that this was a very strategic theme, because you want to make progress with regards to prescriptive authority for nurses in your country. I hope you have been able to gather enough information, and certainly there are now you put faces into some of the experts of different countries in terms of maybe future or more information gathering towards the goal. And we wish you luck. From what I learned, it's still working progress with regards to prescriptive authority in most of the countries. And I think there's a lot to be learned and to be shared on how we have moved forward in terms of providing really, truly great care, especially among the most vulnerable, and especially in the rural communities where access to care is a big issue. So thank you so much, everyone, Colombia team, as usual. And that coffee thing, I have to get my Colombian coffee.
Thank you so much, Dr. Danette. It was our pleasure to organize this hub. Thank you for the opportunity to do it. Cristian, ¿tenemos la foto ya?
Ya fue tomado.
Okay. So for closing this meeting, I want to give the word to Daniel Guerrero, our PhD students in the United States, for some conclusions. And finally, we have a special music intervention by the son of Lorena Sanchez, Dr. Lorena Sanchez, that is a famous musician here in Colombia. Daniel?
Well, thank you very much, everyone, for participating in this virtual global health hub. It has been very informative. It has shown us some lights on what are the next steps to work towards advanced practice nurses in Colombia. So I'm just going to do a quick recap of our presentations today. We had first the opening plenary by Dr. Champion, where she shared her experience in how she got from being a BSN nurse to an advanced practice nurse, a DNP PhD certified nurse specialist in adults, and then in psychiatric and mental health. She also has a goal before retiring, and her belief is to be able to have a complete full practice, well, in the state of Texas in her case, that is not restricted by MDs or physicians. So, I mean, that you have the complete autonomy. And she also believes that prescription medication will allow you to give a more comprehensive care. However, prescribing a medication is not the only thing that nurses can do, and it cannot be defined as care. So it's just a small component, and she said that about 60% of what she does in her clinical practice that she has every week in rural areas is devised or focused specifically in the person, in the individual, in the mental health component. So just prescribing is a small part of the entire world that nurses can provide. Then we started our presentations with Brazil. We had the presentation by Daniela, and she was sharing her experience and how some of the states in Brazil have already legalized, or there is some authority for nurses to prescribe some medications. However, it's only in underserved and rural areas, which requires more work for all nurses to be able to prescribe medications if that's the way they want to go. If the clinical settings are providing care, it's the way they want to go. So they also require a bigger educational offer, so more advanced practice curriculums that need to be fulfilled, and they also require a more specialized professionals to be able to educate and train the future advanced practice nurses. Then we went to Japan. We went to the other side of the world when we had the presentation by Dr. Suga, where she shared the experience of a nurse practitioner's education in Japan, that it's overall trying to improve the health, the needs of the system and the quality of life of their citizens. She first gave some interesting statistics about how there are 269 MDs per 100,000 inhabitants, and nurses it's like 1,000, so it's almost 5 times more, sorry, nurses than MDs, which, I mean, it's a great impact. She gave them some like timeline, some history, how the first program was created in 2008. However, the first certification program was made in 2011, and there have been working towards creating an international a program that meets international requirements. Some of these processes have been like, then the nurses have like 4 main areas which they can work towards. Right now, like the education that they have 415 hours of common education between the advanced practice nurses, and then 15 to 72 hours on focused education for the specialty they're going through. However, nurses cannot diagnose nor prescribe medications here. So we have an advanced practice nurse, but they cannot prescribe medications. And they're working towards the next steps to have a bigger authority and independency in their clinical practice. Then we went to Turkey, where they shared some of their experience, how they have 4 programs, the BSN, the MSN, and the PhD programs. However, they don't have any advanced practice nurse programs or DMPs. There are some legal regulations that provide the ability to keep on working on that. And nurses act under the direct supervision of the MDs, except in the case of emergencies. That's an important thing to highlight, because that is a main point or a common point throughout the presentations that we've seen here today. And in 2016, the government announced a law that allows nurses to prescribe medications. So since that point, they have been working towards a more independent practice for nurses. Then we went to Thailand, where they emphasized that the MDs have the highest level of prescription authority. Nurses do have prescription authority there, and they have like 2 types of MPs that can prescribe medications: is the general MP and the advanced community MP. They're both in the master's level. However, they have more than 2 programs of MP programs in Thailand. In their bachelor's program, they are educated and trained on how to administer safely a medication, and they can administer 17 drug categories and 52 medications. While they're taking their education in the MPs, they take a 4-credit course, and it's the basic diverse treatment that they have. And they have the Support Medication Act that will facilitate the collaboration among professionals. Then we have I think I see a raised hand by Dr. Rabie. Dr. Rabie.
I want to add some things because I think there is a misunderstanding here. Because in Turkey at the moment it's illegal to prescribe by nurses. Only nurses can implement medication ordered by physicians, and we have advanced practice nurses, but specialist nurses in some areas. In some areas, but they don't have prescription, authorization. So since 1928, it's forbidden to prescribe any prescription by any health professionals other than doctors and physicians. But sometimes we had efforts by Turkish Nurses Organ Associations in the 80s and in 2007, as far as I remember, or just before that. And in 2016, our president announced that nurses should have that authority, prescription authority. But I think nurses were not so not so willing to prescribe, because I think in generally in Turkey, nursing leaders thinks that it's not within the scope of nursing care, Therefore, I don't know, maybe if they did use that opportunity, the announcement of our president, maybe they would change the law. But still, according to Nursing Act, nurses don't have any prescription authority in Turkey. Thank you.
Thank you, Dr. Rabia. So then we went to the US, where we had another overcap and review of the advanced practice nurse situation here in the US. We have 4 main categories: the MPs, the certified nurse specialist, certified nurse midwives, and the certified registered nurse anesthesiologist. And well, it's a little review here, and they have the 3 types of practice: the full practice, the reduced practice, and the restrictive practice. Then we went to Chile, where we have the presentation by Dr. Marquez, where she shared some statistics in the country, and she shared that the nurses don't have any prescription authority. However, in Latin America, there are no, this is the first program of advanced practice nurses, but no nurses here have a prescription authority provided by law. And then we went to Colombia, where we shared some legal basis that we have that allows the nurses program to continue their education for their development of the profession. And that we're working towards providing an advanced practice nurse program here in Colombia. So quick conclusions here. We have a lot of work to do. There are some division even between nurses in whether we should be or we shouldn't be prescribing medication, but that's a point of discussion, and that will allow us and it will enrich our profession. Some countries already have made steps towards a full independent practice. However, most of us still have some supervision by MDs, and MDs overall have the highest level of prescription authority in most of the countries. So we still need some regulations in most of the countries, and we still need more training and education in nurses to be able to prescribe medications and to have advanced practice education nurses. And there's an overall shortage of experienced faculty to be able to educate the future advanced practice nurses. So those are my conclusions of today's presentations. Thank you very much, Dr. Carreño.
Thank you, Daniel. We have a lot of cats today in our meeting. They are so lovely. So we are going to move to the musical intervention by Daniel Mendoza, please.
Greetings from Colombia. My name is Daniel Mendoza. I want to congratulate you all for the hard work you have completed on this hub. Today I have brought you a gift to welcome Christmas. The first one is the most renowned Christmas carol around the world, Silent Night. The second is a Colombian villancico that talks about the ride of a singer on his donkey arriving at the Christmas scene in Bethlehem. I hope you enjoy them. Big hugs. Silent night, holy night, all is calm, all is bright, round your virgin mother and child, holy infant so tender and mild, sleeping heavenly peace, sleeping heavenly peace. Noche de paz, noche de amor, todo duerme en derredor, solo velan en la oscuridad los pastores que en el campo están y la estrella de Belén y la estrella de Belén y la estrella de Belén y la estrella de Belén. Con mi burrito sabanero voy camino de Belén, con mi burrito sabanero voy camino de Belén. Si me ven, voy camino de Belén. Si me ven, voy camino de Belén. El lucerito mañanero ilumina mi sendero, el lucerito mañanero ilumina mi sendero. Si me ven, voy camino de Belén. Si me ven, voy camino de Belén. Tuki, tuki, tuki, tuki, tuki, tuki, tuki, ta. Apúrate mi burrito que ya vamos a llegar. Tuki, tuki, tuki, tuki, tuki, tuki, tuki, tu. Apúrate mi burrito, vamos a ver a Jesús. Con mi cuatrico voy cantando y mi burrito va trotando. Con mi cuatrico voy cantando y mi burrito va trotando. Si me ven, voy camino de Belén. Si me ven, voy camino de Belén. Si me ven, voy camino de Belén. Si me ven, voy camino de Belén. Greetings from Colombia. My name is Daniel.
Thank you so much, Daniel. And Dr. Lorena, please close this meeting.
Okay, thank you all for this excellent work. The topics we have discussed during this year show us the great challenges we face as a profession, as a science. Thank you all for sharing your experiences and giving visibility to nursing. Our appreciation, it has been an honor to share this hope with you. Thank you so much. Feliz Navidad.
Thank you. Have a great holidays. Bye.
Feliz Navidad.
See you next year.
Merry Christmas and a Happy New Year to everyone.
Yes,
Thank
yes.
you
Thank you.
for
Thank
this program to the end of the year.
Gracias.
Happy
Feliz
holidays,
Navidad.
everyone.
Feliz Navidad.
Feliz
Feliz Navidad.
Merry Christmas.
Feliz Navidad a todos.
Best
See
wishes for the
you.
holidays.
Feliz Año Nuevo también.
Thank you.
Gracias,
Thank you.
Muchas
bye.
gracias, Colombia.
Gracias a ti.
See you.
Muchas gracias a todos. Buenas
Love the
noches.
hair, Dr. Lorena.